My name is Han Wayne, and I am a physical therapist in inpatient rehab at Largo West Hospital in Largo, Florida. I will be walking you through this case study of TM, who was a 42-year-old male with an acute left MCA and bilateral cerebellum CVA, and how high-intensity gait training was implemented to improve his functional outcome during his inpatient rehab stay. This case was developed by myself to assist with an implementation project for the ANPT's Task Force for Locomotor CPG for chronic SCI, TBI, and CVA. I have no personal disclosure, and a written consent was granted by the participant in this case study. I would also like to acknowledge Angelia Johnson, who was my student at the time. She assisted me in the treatment and implementation of high-intensity gait training for this patient. TM was a 42-year-old male with a past medical history of hypertension that was not well managed and hyperlipidemia. He was independent with all mobility without an assistive device, and also was independent with all ADLs and IADLs prior to his stroke. He also owned an air conditioner business and had a very active lifestyle. He came to the ER on January 26, 2021 with slurred speech, right facial droop, right-sided weakness that was worse in the arm than the leg, and balance issue. He was experiencing a hypertensive emergency with blood pressure in the ER in the 170s over 110s. His NIHS score on arrival was 10. He was then diagnosed with left MCA and bilateral cerebellum CVA. He was admitted to our inpatient rehab facility on February 2, 2021. Upon initial evaluation, the patient body function and structures impairments included right hemiplegia and hemiparesis. He had 1 out of 5 strength in the right ankle dorsiflexor and hip abductor, and 3 out of 5 in the right knee extensor. He had mild impairment with coordination testing, with heel to shin, finger to nose, and rapid alternative movement on the left side. The right side was not able to be tested because of weakness. He also had a 1+ on the modified Ashworth scale at the ankle on the right lower extremity. His right upper extremity was hypotonic. However, he did have movement in partial range against gravity in shoulder elevation and elbow flexion. His activity limitation and his goals will be presented in the next couple slides. Participation. He owned an air conditioning business. His job required him to be on his feet for the majority of the day, that also included crawling and lifting. Before his stroke, he enjoyed fishing and hiking, so he was pretty active before. His girlfriend worked during the day, so he would not have caregiver support during those times. His positive personal factors included he was very young, he was very motivated and was active prior to his stroke, and he was admitted to inpatient rehab within 6 days. During his initial evaluation, he needed min assist for rolling toward the left side due to the right-sided weakness, and supervision for supine to and from sit. During transfers, he needed mod assist to perform squat pivot transfer. He was impulsive and needed use of the upper extremity for steadying. During ambulation, he needed max assist to ambulate without an assist device and closed wheelchair follow due to impaired balance and poor safety awareness. He was not able to ambulate more than 50 feet because of high blood pressure. During stairs negotiation, he needed max assist for steadying and needed facilitation to place the right lower extremity on the step and manual knee blocking to prevent knee buckling. He showed poor eccentric control during descending and was not able to complete more than 4 steps because of the high blood pressure. He scored a 26 out of 56 on the Berg balance scale, demonstrating high fall risk. He walked 570 feet with multiple standing rest breaks, ranging from 30 to 45 seconds during the 6-minute walk test. The 6-minute walk test was not able to be completed until the second week due to hypertension at initial evaluation. The patient and family goals were to walk, to get home with his significant other, to continue his progress at a local gym after outpatient therapy, to get back to his job, which consists of being able to perform his job duties physically and managing his business financially. The intervention selected for this individual was based on the Locomotion CPG, specifically Action Statement Number 1 and Action Statement Number 5. Action Statement Number 1 states that clinicians should use moderate to high intensity walking training to improve walking speed and distance. And Action Statement Number 5 states that clinicians may consider use of circuit training or combined strategies, providing balance, strength, and aerobic exercises to improve walking speed and distance. This patient was usually seen for 90 to 120 minutes of individual physical therapy treatment during his stay at our inpatient rehab facility. The major focus of each treatment session was high-intensity, high-repetition gait training for at least 60 to 75 minutes while maintaining the heart rate in the appropriate aerobic zone. Also, to address the patient-driven goal of maintaining his progress at a local gym, we also built in circuit training of strength, agility, plyometric, and aerobic training for the remainder of the treatment session. Circuit training was also utilized in between walking bouts to maintain a higher heart rate as an active rest break. Because the Locomotion CPG specifically focused on population with chronic CVA, TBI, and SCI, a literature review was performed to understand the efficacy and effect of high-intensity gait training on individuals with acute and subacute stroke. The first study, by Halloran et al. In 2014, concluded that stepping training at high intensity in variable contexts shows significant improvement in self-selected speed, fastest speed, sporadic single limb stance, and walking endurance. High-intensity gait training was well tolerated by participants with no adverse events. The second study by Hornby et al. In 2015 specifically looked at stepping practice during inpatient rehab and showed that providing focused, repeated stepping training during inpatient rehab was feasible. This type of intervention also showed positive improvement in the 6-minute walk test, the Burt Balance Scale, and most importantly, discharge location and level assistance at discharge. The last study was a randomized controlled trial by Hornby et al. In 2015, and it demonstrated that stepping practice at high intensity in variable contexts showed a significant improvement in self-selected gait speed, the 6-minute walk test, and sporadic single limb stance compared to conventional therapy. Overall, it can be concluded that high-intensity, high-repetition gait training is feasible in an inpatient rehab setting. It is also important to note that stepping practice should include not only forward direction, but be provided in variable contexts, such as multidirectional steppings, stairs, and different environments. Lastly, the choice of using an AFO or FES device during physical therapy session was made based on the CPG for the use of AFO and FES post-stroke. This allowed the patient to achieve higher repetition of stepping while maintaining his safety. Looking at the FITT guidelines, we want to prioritize high-intensity gait training as much as possible during 90 minutes of his therapy treatment for 5 times per week. We wanted him to work at 70 to 80% heart rate reserve as calculated below at 146 to 157 beats per minute. The RPE goal was to be greater than or equal to 14 to 17. Because of his high blood pressure, we was instructed by the medicine team to keep the systolic blood pressure below 140. The type of intervention included high-intensity gait training with time split between overground training, treadmill training, stairs, agility, and functional task training. The Locomotion CPG develop different resources to assist clinicians with the implementation of high-intensity gait training. As shown here is a calculator for heart rate reserve to determine targeted heart rate. There is also another one for heart rate max. You can access this calculator and other resources on neuropt.org under the Locomotion CPG or through the link on this slide. TM was not able to participate in high-intensity gait training during first week of rehab because of high blood pressure. His blood pressure goal was to keep systolic blood pressure under 140, and this was determined by the medical team. This is different than the ACSM guideline, which say that a systolic blood pressure exceeds 250 and or diastolic blood pressure exceeds 115 should be used as a relative indications to terminate exercise. However, we need to follow the medical team recommendation because of the patient's past medical history. When the patient was able to participate in therapy, intervention was focused on functional tasks, dynamic balance, and functional strength training. High-intensity gait training was deferred until better control of blood pressure and that the patient was cleared by the medical team. This slide shows different essential biomechanical subcomponents of gait that were manipulated once TM was able to tolerate and able to participate in high-intensity gait training. We focus on stance control, limb advancement, propulsion, and balance. Specifically, we really spend the bulk of our time focusing on propulsion as it is a biggest energy expenditure of gait, as well as balance in both the sagittal and frontal planes. For the second week of intervention, TM was able to participate in 4 sessions of high-intensity gait training. For intensity, he was able to maintain his heart rate between 70 to 80% heart rate reserve, which in his case was between 144 and 168. His RPE report was between 13 and 17. For the majority of the time, we were able to keep his blood pressure below 140 per medical team guideline. He was seen between 90 to 120 minutes per session, and at least 60 minutes was spent doing high-intensity stepping practice while keeping the heart rate in the appropriate intensity and heart rate zone. Rest break was given as needed to keep systolic blood pressure below 140. The time spent during the session was split between treadmill training and overground training. Note that he also had a right AFO or a right FES device throughout the session. In this case, we used the BioNest L300. On the treadmill, a harness system was used for safety catch only. He was able to achieve a max speed of 1 to 2 miles per hour for up to 2 bounds of 10 minutes. For overground walking, he performed forward, backward walking, and lateral walking with verbal cues to walk as fast as he can, as well as matching the clinician's walking speed, with and without an assistive device. This activity was then progressed to use a TheraBand to provide a posterior force to challenge his propulsion and dynamic balance. He also performed stair training with ankle weights to challenge limb advancement, and again a TheraBand to provide posterior force to challenge propulsion. He also did some circuit training in the remaining 30 to 40 minutes with the intention to keep his heart rate elevated and to address his going back to the gym goal. During the circuit training, he performed ambulation at max speed and stairs with reciprocal pattern. In between ambulation and stairs, he performed modified jumping jacks and modified squat jumps. During the last week of intervention, TM progressed to not needing an assistive device. However, he still needed a right AFO or a right FES device to clear his foot adequately. He participated in 4 sessions of high-intensity gait training before discharge home. For intensity, he was able to maintain a heart rate of 70 to 90% heart rate reserve, an RPE rating scale of 13 to 17 without compromising his blood pressure. He was seen for typically 90 to 120 minutes, and at least 60 minutes of these sessions was spent during high-intensity gait training. He actually was able to tolerate for more than 60 minutes for most of these sessions. During the training, we split our time between treadmill training and overground training. Again, on the treadmill, a harness system was used for safety catch only, and no body weight support was provided. He walked between 2 and 3 miles per hour for 15 minutes, also 2.7 to 2.9 miles per hour at a 2% incline for 10 minutes, and also jogged at 3.2 miles per hour for 2 minutes at a time. For overground walking, he did forward, backward, sideways walking with verbal cues to walk as fast as he can, and stair training both forward and sideways directions. Again, we use ankle weight to challenge limb advancement and resistance band from behind to work on propulsion and dynamic balance. He also did some outdoor jogging as seen in this video. In the video, the harness system was used for safety catch and to provide safety for both the clinicians and the patient. He was able to jog 200 feet 3 times with rest breaks in between. This slide shows the comparison between admission and discharge outcomes. Initial evaluation was mentioned above, and these are the improvements. In all aspects of functional tasks, the patient improved to become independent with no assistive device. For stairs, he was able to perform a reciprocal pattern for both ascending and descending the stairs. He was also able to perform a full flight of stairs of 21 steps continuously. The bird balance scale improved from 26 to 43 out of 56, and although we did not formally reassess the 6-minute walk test, the patient was able to walk 600 feet in under 3 minutes during high repetition set practice. Here are some barriers and how we problem solve to overcome them. The first one was high blood pressure. We make sure to work closely with the medical team and update them on blood pressure during exertion so that any adjustment can be made. We had to make sure that he was clear medically before we attempt any high intensity training. The second one was time required for equipment setup. We make sure that the session was planned out ahead of time, that we gather all the needed equipment, and that all the equipment was charged after use so that they can be ready to be used again the next day. Having a rehab tech or a student in my case was very helpful because one person can get the patient to the gym and get him ready in the harness system while the other person gather all the needed equipment. The third and last barrier was heart rate monitoring. At first, we were using the portable pulse ox. However, this was very difficult to carry around and the sensor kept slipping off the finger. Later on, I was able to purchase a used polar watch with a chest strap, and we were doing a much better job at continuously monitoring the heart rate. Lastly, here are some takeaway points and clinical pearls. The first takeaway point is that despite not focusing on transfer training or standing balance, this patient still showed improvement in these domains via skill transference with prioritizing high-intensity gait training. The second takeaway point is that high-intensity gait training is safe for patients who are medically complex. In this case, we needed to closely monitor the blood pressure and work with the medical team. For those who are thinking about implementing high-intensity gait training at your facility, my biggest advice is just do it. You will learn from trials and errors. You can start with patients with less complexity to build your confidence, and familiarize yourself with the facility equipment. On the Locomotion CPG webpage, there are many useful resources such as the heart rate calculator or sample documentation. You should also advocate for a harness system to ensure patient and clinician safety. A sample justification letter is also provided on the Locomotion CPG webpage. For any additional question, please don't hesitate to reach out. My contact information is provided on the last slide.